Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. Today, we are diving into a crucial area of toxicology, toxic alcohols. For future pharmacists, understanding these compounds is not just important for passing exams. It is essential for being prepared to handle real-world emergencies. In such situations, timely intervention can literally save lives or prevent severe and permanent damage. Let us start with the basics. Alcohols, from a chemical perspective, are a class of hydrocarbons characterized by the presence of a hydroxyl group, which is a pair of oxygen and hydrogen atoms attached to the carbon chain. While all alcohols can be toxic if consumed in excessive amounts, leading to effects such as inebriation and damage to various organs. In a clinical context, the term toxic alcohols generally refers to those alcohols other than ethanol. These are not intended for human ingestion and can be highly dangerous. The most important toxic alcohols to know due to their significant impact on health are methanol, ethylene glycol, and isopropanol. In addition, other substances like diethylene glycol and propylene glycol are relevant because they present unique challenges. Each of these chemicals has distinct chemical properties and metabolic pathways. More importantly, they can cause severe delayed toxic effects, which healthcare professionals must understand thoroughly. Now, let us prepare to explore the details and risks associated with these dangerous substances. To prepare for the challenges associated with toxic alcohol poisoning, it is important to understand certain key concepts. First, it is essential to define and classify toxic alcohols. These are alcohols that are harmful when ingested, and they are distinct from ethanol, the alcohol found in beverages. Toxic alcohols can be categorized based on their chemical structures, such as primary, secondary, or diols, also known as glycols. Several toxic alcohols are of particular clinical significance. These include methanol, ethylene glycol, and isopropanol. Other relevant toxic alcohols might include diethylene glycol and propylene glycol. Understanding the pathophysiology and clinical effects of these substances is crucial. For example, methanol's toxicity mainly originates from its metabolite, formic acid. This leads to severe metabolic acidosis characterized by an increased anion gap and is associated with visual impairments and lesions in the basal ganglia of the brain. Ethylene glycol, another toxic alcohol, is metabolized into substances such as glycolic acid and oxalic acid. These metabolites are responsible for causing severe metabolic acidosis and can result in acute kidney injury due to calcium oxalate crystal deposits within the kidneys. Isopropanol is metabolized into acetone, which causes ketosis without significant metabolic acidosis. The parent compound, isopropanol, is primarily responsible for central nervous system depression, leading to symptoms such as dizziness or coma. In diagnosing toxic alcohol poisoning, certain surrogate markers are useful. Elevated levels of the anion gap and osmolar gap are indicative of toxic alcohol ingestion. These markers tend to have a reciprocal relationship, which changes over time as the toxins are metabolized. Prompt initial management involves resuscitation and supportive care. It is important to note that gastrointestinal decontamination has a limited role once poisoning has occurred. A key aspect of treatment is inhibiting the enzyme alcohol dehydrogenase, which is responsible for converting toxic alcohols into their harmful metabolites. This inhibition prevents further formation of toxic compounds. Two agents used to inhibit alcohol dehydrogenase are fomepizole and ethanol. Fomepizole is often preferred because of its mechanism of action, safety profile, and ease of use. Ethanol can also be used, but has disadvantages including difficulty in administration and potential adverse effects. In cases of severe poisoning, hemodialysis may be necessary to remove toxins directly from the bloodstream. Furthermore, adjunctive therapies such as bicarbonate are employed to correct acidosis, while folate or folinic acid can enhance the metabolism of methanol into less harmful substances. Alcohols are a class of hydrocarbons characterized by the presence of a hydroxyl group, which is a hydroxyl group attached to the carbon chain. The term toxic alcohol specifically refers to alcohols, other than ethanol, that are not meant for human ingestion. Although all alcohols can cause toxicity, significant effects including inebriation and damage to various organs can occur when they are consumed in excess. Among these, methanol, ethylene glycol, and isopropanol are considered the most clinically significant toxic alcohols. Other relevant alcohols that are discussed include diethylene glycol and propylene glycol. Alcohols can be categorized further based on their chemical structure. Primary alcohols, such as methanol and ethanol, have a hydroxyl group located on the terminal carbon atom of the molecule. Secondary alcohols, like isopropanol, also known as 2-propanol, feature a hydroxyl group attached to a middle carbon atom. Molecules that contain two hydroxyl groups are called diols or glycols. An example of this is ethylene glycol, which is known for its sweet taste. Ethylene glycol is specifically referred to as 1,2-ethanoediol. Additionally, glycol ethers form another group of alcohol-related compounds. These are glycols in which one or more hydroxyl groups are attached to a hydrocarbon chain. An example of a glycol ether is diethylene glycol, which is also known as 2,4-dihydroxydiethyl ether. In the comprehensive landscape of toxic alcohol poisonings, methanol is recognized as a highly dangerous compound. Its unique chemical properties, widespread availability, and potential for severe, delayed toxic effects make it a critical focus of study in the field of toxicology. Chemically, methanol, also known as methyl alcohol, colonial spirit, or wood alcohol, is a one-carbon primary alcohol with the chemical formula CH3OH. It appears as a clear, colorless, volatile, and highly flammable liquid that has a weak smell similar to ethanol. The density of methanol is 0.81 grams per milliliter. Methanol distributes throughout the total water compartment of the body, approximately 0.7 liters per kilogram of body weight, and does not bind to proteins. It is important to distinguish methanol from ethanol, as the term toxic alcohol refers to substances that should not be ingested due to their harmful effects. Historically, methanol has been used since ancient times, notably in Egypt where it served as a component of embalming fluids. The molecule was first isolated by Robert Boyle in 1661 through the distillation of boxwood, and he referred to it as the spirit of box. Its molecular structure was later identified in 1834, which led to the adoption of the term methylene. Industrial production of methanol began in 1923. Today, methanol is mainly employed in the manufacturing of other chemical compounds. Methanol poisoning can occur through various routes, with ingestion being the most common. This often involves accidental or intentional consumption. In the United States, over 60% of methanol poisoning cases are linked to windshield washer fluid. Other sources of methanol include consumer products such as model airplane and car fuel, solid cooking fuel like sterno, photocopying fluid, colognes, perfumes, and gas line antifreeze, also known as dry gas. In some regions, such as Tunisia and Turkey, ingestion of cologne is a frequent cause of poisoning. Mass outbreaks of methanol poisoning remain a significant global issue, particularly in developing countries. These outbreaks are often caused by contaminated fermented beverages or illicitly distilled alcoholic drinks, commonly referred to as moonshine. Such incidents can involve hundreds or even thousands of individuals, highlighting the importance of active investigation when multiple cases occur within a short period, typically 3 or more cases within 3 days indicating a potential outbreak. A more recent source of concern has been the abuse of hydraulic fracturing fluid, also known as fracking, which can also lead to methanol poisoning. Methanol can be absorbed into the body in significant amounts through inhalation. This is particularly common when inhaling fumes from carburetor cleaner, often referred to as huffing, which is a form of drug abuse. Additionally, exposure occurs during severe industrial accidents involving large quantities of methanol. While long-term occupational inhalation of methanol typically does not result in severe poisoning, there have been reports of permanent visual damage and even death caused by inhalation exposure. Methanol penetrates the skin much more effectively than ethylene glycol. There have been reports of poisoning through the skin, including cases of severe toxicity and fatalities. These incidents are especially common with prolonged contact or in infants, who have a higher body surface area relative to their body weight. In Turkey, traditional remedies sometimes involve using bandages soaked in methanol, which has led to serious cases of poisoning. The toxicity of methanol is primarily caused by its highly toxic metabolites rather than the parent compound itself. Methanol is slowly metabolized through a process involving successive oxidation by alcohol dehydrogenase and aldehyde dehydrogenase. Initially, methanol is metabolized by alcohol dehydrogenase into formaldehyde. This formaldehyde is then rapidly oxidized by aldehyde dehydrogenase into formic acid, also known as formate. As a result, little formaldehyde accumulates in the serum. Formic acid is the main toxic metabolite responsible for the severe metabolic acidosis and mitochondrial toxicity observed in cases of methanol poisoning. Under normal circumstances, formate is bound by tetrahydrofolate and further metabolized into carbon dioxide and water by the enzyme 10-formyl tetrahydrofolate dehydrogenase. However, in primates, including humans, the folate pool is limited, which leads to the accumulation of formate. The metabolism of methanol by alcohol dehydrogenase follows zero-order kinetics and accounts for approximately 90% of its elimination. When metabolism is inhibited by an antidote, the half-life of methanol is typically between 45 and 80 hours. The toxic effects of methanol are mainly due to the accumulation of formic acid, which inhibits cytochrome oxidase, the enzyme responsible for the final step of mitochondrial electron transport. This inhibition disrupts oxidative phosphorylation, leading to anaerobic metabolism and an increase in lactate production. The resulting metabolic acidosis further worsens the toxic effects. The clinical presentation of methanol poisoning typically follows a biphasic pattern. The initial stage involves a latent period that usually lasts approximately 12 to 24 hours from the time of ingestion until symptoms appear. This period may be extended up to 90 hours if ethanol is consumed concurrently, because ethanol competitively inhibits the metabolism of methanol by the enzyme alcohol dehydrogenase. During this phase, methanol can cause mild depression of the central nervous system and intoxication that resembles alcohol poisoning, although it generally does not produce significant drunkenness. Early symptoms often include irritation of the stomach, nausea, vomiting, and abdominal pain. During the symptomatic phase, which corresponds to stages 2 and 3, severe symptoms emerge as formic acid accumulates in the body. One hallmark of methanol poisoning at this stage is metabolic acidosis, characterized by an elevated anion gap. This condition often becomes severe and prompts the body to compensate through hyperventilation, leading to shortness of breath. Visual impairment is a significant effect caused by formate, a toxic metabolite that damages retinal pigmented epithelial cells and optic nerve cells. Patients may experience a range of visual disturbances, including blurry or hazy vision, color vision defects, and a snowfield visual phenomenon. In some cases, individuals may become totally blind. Upon examination, characteristic findings include central blind spots, hyperemia of the optic disc, pallor of the optic nerve head, swelling of the optic disc, and defects in the afferent pupillary reflex. The damage to the optic nerve can continue to progress for at least 2 years after exposure, and the resulting vision loss is often permanent. Neurological effects are also prominent, particularly because neurons in the basal ganglia are susceptible to formate toxicity. Imaging studies such as cerebral computed tomography scans or magnetic resonance imaging often reveal bilateral lesions in the basal ganglia, especially necrosis of the putamen. Less frequently, the caudate nucleus is involved. These lesions have been observed even in the absence of hypoxia and hypotension, suggesting a direct toxic effect of the metabolite. Some patients may develop Parkinsonism as a consequence of this neurological damage, which is generally permanent. Other organs can also be affected during methanol poisoning. Acute kidney injury and pancreatitis have been reported. Kidney injury may result from myoglobinuria caused by atraumatic rhabdomyolysis or seizures. Additionally, some fatal cases exhibit abnormalities in the liver, esophageal, and gastric mucosal tissues. Cardiac failure and respiratory arrest are also possible complications of the poisoning, emphasizing the severity of the condition. Ethylene glycol is a prominent member of the toxic alcohol class and poses significant health risks when ingested. Having a clear understanding of its chemistry, toxicokinetics, clinical manifestations, and management is essential in the fields of toxicology and emergency medicine. Regarding its chemistry and properties, ethylene glycol is classified as a diol, also known as glycol, meaning it contains two hydroxyl groups. It is a colorless and nearly non-volatile liquid characterized by an aromatic odor. A notable feature of ethylene glycol is its sweet taste. Chemically, it is also referred to as 1,2-ethanediol. Its molecular weight is 62 grams per mole. Ethylene glycol is a widely used chemical, primarily as an antifreeze in internal combustion engines. It is also found in various other products, including degreasing agents, foam stabilizers, metal cleaners, household cleaning products such as detergents, cosmetics, pesticides, paints, and coolant solutions. Because of its sweet taste, ethylene glycol can be involved in criminal poisoning cases, as it is easily added to drinks to poison unsuspecting individuals. Epidemiological data on ethylene glycol poisoning are limited. However, it appears to be more common than methanol intoxication in developed countries. Exposure to ethylene glycol often occurs through accidental ingestion, intentional self-harm, or recreational use. These incidents sometimes lead to outbreaks among young people, sometimes referred to as copycat epidemics. Although skin absorption of ethylene glycol is possible, it penetrates the skin much less effectively than methanol and isopropanol. Inhalation of vapors is not a common route of poisoning because ethylene glycol has low volatility. Ethylene glycol is quickly absorbed into the bloodstream after ingestion, with the highest levels typically observed approximately 1 hour later. Its bioavailability when taken orally is very high, ranging from 92 to 100%. The substance has a volume of distribution of about 0.7 liters per kilogram of body weight and does not bind to proteins in the blood. The toxicity of ethylene glycol is mainly caused by its metabolites rather than the original compound. It is metabolized in the body through a series of oxidation reactions facilitated by alcohol dehydrogenase and aldehyde dehydrogenase enzymes. During this metabolic process, ethylene glycol is sequentially converted into glycoaldehyde, then to glycolic acid, followed by glyoxylic acid, and finally to oxalic acid. These metabolites, especially the acids, are significantly more toxic than ethylene glycol itself. Throughout this process, nicotinamide adenine dinucleotide, in its oxidized form, is reduced to its reduced form, which is an important step in the body's metabolic reactions. The pathophysiology of ethylene glycol toxicity is complex. The severe metabolic acidosis associated with this toxicity is primarily caused by glycolic acid. Additionally, oxalic acid, which is a terminal metabolite, forms insoluble calcium oxalate monohydrate crystals that precipitate in the renal tubules, leading to acute kidney injury. The deposition of these crystals in the renal tubules is considered the main mechanism behind the nephrotoxicity. Furthermore, calcium oxalate monohydrate crystals have been found in brain tissue during autopsy. Ethylene glycol itself causes central nervous system depression and inebriation, effects similar to those produced by alcohol. Hypocalcemia can also occur due to the precipitation of calcium oxalate, which may result in the prolongation of the QT interval on electrocardiograms and lead to ventricular dysrhythmias. Other occasional effects include liver failure and Parkinsonism. Radiological observations in poisoned patients often reveal pulmonary infiltrates, which are thought to be non-infectious and may stem from an inflammatory reaction triggered by calcium oxalate crystal precipitation in the lungs. Massive ingestions of ethylene glycol without sufficient metabolite elevation can be fatal, likely due to direct toxicity, causing respiratory depression. The clinical syndrome of ethylene glycol poisoning is typically described in 3 overlapping stages. The first stage, known as central nervous system depression, occurs within 30 minutes to 12 hours after ingestion. During this phase, the symptoms resemble ethanol intoxication, including gastric irritation such as pain, nausea, and vomiting. Patients may also exhibit signs of inebriation, such as difficulty with coordination and nystagmus, and in some cases, progress to central nervous system depression, cerebral edema, or seizures. The second stage, which occurs between 12 and 24 hours, involves cardiopulmonary complications. These are characterized by myocardial dysfunction, shock, rapid breathing, and the development of acute respiratory distress syndrome. The third stage occurs between 24 and 72 hours, primarily marked by renal failure caused by the deposition of oxalate crystals in the kidneys. Additionally, some survivors may develop late neurological sequelae, including bilateral paralysis of the facial nerve and peripheral neuropathy. The onset of symptoms can sometimes be delayed up to 4 days if ethanol has been co-ingested because ethanol inhibits the metabolism of ethylene glycol. Isopropanol, also known as isopropyl alcohol, 2-propanol, or propan, 2-OL, holds a unique position within the spectrum of toxic alcohols poisoning, primarily due to its distinct metabolic pathway and clinical presentation. It is a compound frequently encountered in various household and industrial products. Isopropanol is a clear, colorless, and volatile secondary alcohol. It has a bitter taste and a fruity odor that resembles that of acetone. Unlike primary alcohols such as methanol and ethanol, isopropanol is metabolized by the liver enzyme known as alcohol dehydrogenase into acetone. As a secondary alcohol, it is converted into a ketone, specifically acetone, but it is not further oxidized to a carboxylic acid by the enzyme aldehyde dehydrogenase. This chemical characteristic is essential for understanding its toxicological profile. A small amount of isopropanol is excreted unchanged in the urine and through expired air. Isopropanol is readily available and widely used. It is most commonly found as rubbing alcohol, typically in a 70% volume solution in water. It also serves as a solvent in numerous household, cosmetic, and topical pharmaceutical products, as well as in hand sanitizers and de-icing agents. Because of its ubiquitous nature, low cost, and its name containing alcohol, isopropanol ingestions are reported as the most frequent toxic alcohol exposure to U.S. poison control centers annually. These exposures often occur in alcoholics who use it as an inexpensive and accessible substitute for ethanol. However, a significant number of exposures also occur in small children, either through direct ingestion or through prolonged or repeated dermal and inhalational contact. For instance, children may develop toxicity from bathing or sponge bathing with isopropanol to reduce fever. Occupational exposure in adults can also happen via dermal and inhalational routes. Systemic toxicity has also been reported after rectal administration of isopropanol. Isopropanol is absorbed quickly after ingestion, with peak serum concentrations typically occurring within 30 to 60 minutes. Its volume of distribution ranges from 0.45 to 0.7 liters per kilogram, and it binds negligibly to proteins. The half-life of isopropanol is approximately 2 to 8 hours, whereas its metabolite, acetone, has a longer half-life of 7.7 to 27.7 hours. Unlike methanol and ethylene glycol, whose toxicity is primarily mediated by their acidic metabolites, isopropanol itself appears to be the main chemical responsible for depression of the central nervous system. The onset of neurological symptoms usually correlates with peak serum levels of isopropanol, and patients generally show improvement as these levels decline. However, prolonged central nervous system depression can occur even as isopropanol levels decrease, particularly if serum levels of acetone are increasing. This suggests that acetone also contributes to the neurological effects associated with isopropanol poisoning. The primary effects of isopropanol toxicity include depression of the central nervous system, irritation of the gastrointestinal tract, and the development of ketosis. Isopropanol is estimated to have twice the intoxicating effect of ethanol at similar blood concentrations. Its effects can occur rapidly and can be severe. This heightened effect may be due to its higher molecular weight or the additional influence of acetone, a metabolite of isopropanol. Symptoms of intoxication range from mild inebriation to deep coma. Severe cases can involve respiratory depression and low blood pressure. These effects are believed to result from peripheral blood vessel dilation and depression of the brainstem. In response to low blood pressure, a rapid increase in heart rate is often observed as a compensatory mechanism. Additionally, signs related to coordination and movement disturbances, such as cerebellar signs, are frequently seen. These may include loss of balance, rapid involuntary eye movements, and difficulty speaking. While less common than with ethanol poisoning, seizures have been reported, especially in infants. Gastrointestinal effects of isopropanol are common and can include nausea, vomiting, and abdominal pain. Isopropanol may cause gastritis and irritation of the mucous membranes, which can sometimes lead to severe complications such as hemorrhagic gastritis. Although these effects are often attributed to direct local irritation, there has been at least one reported case of hemorrhagic gastritis following percutaneous exposure, indicating that other mechanisms might be involved. Additionally, elevated levels of serum transaminases have been observed in affected individuals. The hallmark of isopropanol toxicity is the presence of ketosis without accompanying metabolic acidosis. This occurs because isopropanol is metabolized into acetone, which does not produce a carboxylic acid during the process. Patients affected by this condition may exhibit a distinct ketotic or sweet smell on their breath, which results from the exhalation of acetone. Additionally, mild hyperglycemia can sometimes be observed. However, it is important to always rule out hypoglycemia in patients experiencing central nervous system depression. Renal insufficiency and failure can occur as a result of low blood pressure and muscle breakdown. It is important to consider muscle breakdown, also known as rhabdomyolysis, especially in patients who are unconscious, particularly when the duration of unconsciousness is unknown. Dermal exposures can lead to various skin conditions, including contact dermatitis, allergic dermatitis, and skin ripping due to skin disintegrating. These issues are more common in occupational settings or when substances are used to reduce fever in children. Sometimes, such exposures can even cause chemical burns. Propylene glycol, also known as 1,2-propanediol, occupies a unique place within the broader context of toxic alcohol poisoning. Although it shares some chemical similarities with more notoriously toxic glycols like ethylene glycol, its metabolic profile and the clinical picture it presents often differentiated, necessitating a specific understanding for proper management. Chemically, propylene glycol is a diol, which means it has two hydroxyl groups. It is a colorless liquid and structurally similar to diethylene glycol. This compound is widely used as an alternative to ethylene glycol in environmentally safe antifreeze products. In addition to its industrial applications, propylene glycol is commonly used as a diluent or solvent in numerous pharmaceutical formulations. It is found in intravenous medications such as phenytoin and lorazepam, and it is also present in various cosmetic products. Unlike methanol and ethylene glycol, the parent compounds of which are not primarily toxic, but whose metabolites are, the metabolism of propylene glycol is somewhat different. It is metabolized successively by alcohol dehydrogenase and aldehyde dehydrogenase enzymes. This metabolic process results in the formation of lactate, acetate, and pyruvate. These phases of metabolism contribute to the understanding of how propylene glycol impacts the body and its role in various physiological and pathological conditions. A critical aspect of propylene glycol metabolism is its conversion to lactate. This can result in exceptionally high lactate concentrations and a metabolic acidosis. While such high lactate levels from other disease processes would typically be considered incompatible with life and reflect underlying anaerobic metabolism, the lactic acidosis caused by propylene glycol is surprisingly well tolerated. This is because it represents the direct metabolism of propylene glycol itself rather than an indicator of severe anaerobic metabolism or tissue hypoperfusion. This lactate is then rapidly cleared by oxidation to pyruvate, which subsequently enters normal carbohydrate metabolism. Propylene glycol, being an osmotically active compound, can also elevate the osmolar gap. The toxicological significance of propylene glycol is generally considered low, especially when it is used in cosmetics. However, its effects become more concerning when it is administered as a diluent in intravenous drug formulations or in cases of overdose. In such situations, propylene glycol can accumulate in the body, particularly if renal function is impaired. This accumulation can lead to central nervous system depression, which may result in symptoms such as drowsiness, dizziness, and in severe cases, seizures. There has been at least one reported case involving children, where propylene glycol intoxication was followed by central nervous system depression and seizures. Propylene glycol overdose has also been associated with severe metabolic disturbances. Notably, cases of lactic acidosis have been reported, with lactate concentrations reaching up to 24 millimoles per liter or 216 milligrams per deciliter, following intravenous medication administration. In instances of overdose, levels of D-lactate, a more specific form of lactate, have been found to reach as high as 110 millimoles per liter. While central nervous system depression has been observed, there does not seem to be a clear correlation between serum propylene glycol levels and toxicity, based on the limited number of reported cases. For example, one patient with a serum propylene glycol concentration of 760 milligrams per deciliter did not show signs of central nervous system depression. In contrast, another patient with a serum level of 70 milligrams per deciliter experienced stupor and metabolic acidosis. In the broader context of toxic alcohol poisoning, benzyl alcohol, also known as phenylmethanol, is recognized as a clinically relevant toxic alcohol. Although it shares the classification of toxic alcohols with substances like methanol, ethylene glycol, and isopropanol, its particular clinical significance stems from its historical applications and the severe adverse events associated with it, especially among vulnerable populations. Chemically, benzyl alcohol was previously used as a preservative in intravenous solutions. This historical use underscores its importance in pharmaceutical formulations and raises concerns about excipient safety in pharmacy education. Benzyl alcohol became infamous for causing a severe, often fatal condition known as neonatal gasping syndrome. This syndrome affected newborns and involved dysfunction across multiple organ systems, metabolic acidosis, and, ultimately, death. The toxicity of benzyl alcohol is due to its metabolism into benzoic acid and hippuric acid, compounds responsible for the observed adverse effects. This historical episode highlights the crucial need for stringent evaluations of all components included in drug products, particularly those administered to neonates, given their unique metabolic capabilities and vulnerabilities. As a result, benzyl alcohol is no longer used in neonatal medicine. In the challenging clinical landscape of poisoning by toxic alcohols, effective diagnostic testing is essential for timely intervention and for improving patient outcomes. Because these intoxications are often critical, adopting a comprehensive and strategic approach to both laboratory and clinical assessment is vital, particularly when a definitive history of exposure is unavailable. Diagnosing poisoning from toxic alcohols can be difficult, especially in cases where there is no clear history of ingestion or when the presence of ethanol in the system extends the latent period before symptoms appear. Recognizing the condition early is crucial, as delays in starting treatment can lead to worse patient outcomes. It is important not to wait for serum levels of toxic alcohols before beginning treatment if poisoning is suspected. Maintaining a high level of suspicion is vital because some toxic alcohols, such as benzyl alcohol and propylene glycol, are not routinely measured using gas chromatography, which creates additional diagnostic challenges. The ideal approach to diagnosing toxic alcohol poisoning involves measuring the serum concentrations of the parent toxic alcohols, such as methanol, ethylene glycol, and isopropanol, as well as their specific toxic metabolites, including formate, oxalate, and glycolate. The most common method for determining these concentrations is gas chromatography, sometimes confirmed with mass spectrometry. However, these advanced techniques are often unavailable around the clock in many hospital laboratories, resulting in delays that can hinder prompt clinical decision-making. In many cases, these tests are sent out to external laboratories, and the results may arrive too late to influence immediate treatment. Emerging technologies offer the potential for more accessible testing. Enzymatic assays for methanol, formic acid, ethylene glycol, and glycolic acid are newer methods that could become more widely available in clinical settings. Additionally, a dry chemistry strip-based analysis for bedside measurement of formate is under development. Capillary electrophoresis is another promising technique that could rapidly determine serum formate concentration using small sample sizes and at a lower cost. When testing for ethylene glycol, it is essential to specifically request this analysis, as general volatile alcohol panels might not include it. Enzymatic assays, which have been approved for veterinary use, can be effective in confirming ethylene glycol poisoning in humans, although they may produce false positives if propylene glycol is present. Some experts recommend routine testing for glycolic acid in addition to the parent compound. For methanol poisoning, measuring serum formate concentrations is particularly valuable, especially in patients who present late after ingestion when the parent alcohol may no longer be detectable. In one series, formate was identified in 97% of fatal methanol poisoning cases. Levels exceeding 4 millimoles per liter have been associated with visual toxicity, and concentrations over 11 millimoles per liter with permanent visual or neurological damage. Levels of isopropanol are best measured using headspace gas chromatography. If enzymatic assays based on alcohol dehydrogenase are used, there is a risk of misinterpreting isopropanol levels as ethanol, which can result in falsely low readings. In terms of interpretation, elevated levels of these substances are considered potentially toxic. For example, methanol or ethylene glycol levels above 20 milligrams per deciliter, or methanol levels over 6.2 millimoles per liter, and ethylene glycol levels exceeding 3.2 millimoles per liter are often used as thresholds. However, these cutoff points are generally conservative and based on consensus rather than definitive evidence. Patients who present late may have low or undetectable levels of the parent alcohol, making reliance on metabolite levels essential. Proper sample handling is crucial, especially for volatile alcohols like methanol and isopropanol, as evaporation can lead to falsely low results. Due to limitations in specific assays used to detect toxic alcohols, healthcare providers often rely on surrogate markers for diagnosis. One important marker is the anion gap, which becomes elevated in cases of toxic alcohol poisoning. An increased anion gap typically indicates the presence of unmeasured anions, such as organic acid metabolites resulting from the metabolism of toxic alcohols like methanol or ethylene glycol. The development of acidosis associated with toxic alcohol ingestion takes time, usually between 16 to 24 hours for methanol. In the early stages after ingestion or if ethanol has been co-ingested, the anion gap may remain normal, and its absence does not rule out poisoning. When diagnosing, it is essential to exclude other common causes of anion gap metabolic acidosis, such as elevated lactate levels or ketoacidosis. However, in cases of methanol or ethylene glycol poisoning, lactate levels may be elevated due to the inhibition of oxidative phosphorylation by formate, a toxic metabolite, which increases the ratio of NADH to NAD+. While an elevated anion gap alone is not specific to toxic alcohol poisoning, a rapidly increasing or severely elevated anion gap, such as bicarbonate levels dropping to 1 or 2 millimoles per liter, is highly concerning for either toxic alcohol exposure or severe sepsis. Monitoring the anion gap over time through serial measurements is particularly sensitive in detecting toxic alcohol poisoning, especially in cases where ethanol levels are negative or after the metabolism of ethanol has occurred. The osmolar gap is an important but imperfect marker in assessing toxic alcohol poisoning. An elevated osmolar gap can serve as an early indicator because parent alcohols are osmotically active. For instance, Markedly elevated osmolar gaps above 30 milliosmoles per kilogram for diethylene glycol or above 50 milliosmoles per kilogram for other toxic alcohols are highly suggestive of exposure. However, the osmolar gap is neither highly sensitive nor specific. A normal value does not rule out poisoning, and the test has poor positive and negative predictive value. Additionally, there is no standardized method for calculation, no consensus on what constitutes a normal upper limit, and normal ranges can vary among laboratories. The relationship between the osmolar gap and the anion gap is reciprocal over time. Early after alcohol ingestion, alcohols increase the osmolar gap without affecting the anion gap. As the alcohols metabolize into acid anions, the anion gap rises while the osmolar gap decreases. Therefore, patients presenting late after ingestion may have a normal osmolar gap despite significant poisoning. Ethanol concentration is a crucial aspect of clinical assessment. Ethanol is a preferred substrate for alcohol dehydrogenase, which makes it protective when co-ingested with toxic alcohols, as it prevents the formation of harmful metabolites. When the serum ethanol concentration approaches 100 milligrams per deciliter, 22 millimoles per liter, it virtually rules out toxic alcohols as the cause of an unknown anion gap metabolic acidosis, because such a concentration would have prevented the formation of toxic metabolites. Conversely, a low or zero ethanol level in an intoxicated patient should prompt further investigation for other underlying pathologies. It is important to note that breath alcohol analyzers can sometimes produce false positive results in the presence of methanol. Therefore, confirmation of ethanol levels with serum testing is recommended to ensure accurate diagnosis. Lactate concentration can be elevated due to various causes, including certain poisonings. Both methanol and ethylene glycol poisoning can lead to increased lactate levels. In cases of methanol poisoning, formate inhibits oxidative phosphorylation, which results in anaerobic metabolism and subsequently raises lactate levels. Additionally, the metabolism of all alcohols increases the ratio of NADH to NAD+ in the body, favoring the conversion of pyruvate into lactate. Factors such as low blood pressure, organ failure, and a deficiency in thiamine, an issue often found in alcoholics, also contribute to elevated lactate levels. There is also a phenomenon known as the lactate gap, which is particularly relevant in ethylene glycol poisoning. In this situation, the glycolate metabolite can cause falsely elevated lactate readings when measured by certain arterial blood gas analyzers, especially those that utilize lactate oxidase. This discrepancy between point-of-care and laboratory measurements of lactate indirectly indicates the presence of glycolate, thus forming the lactate gap. Ingesting propylene glycol can also result in elevated lactate levels. However, in this case, the measured increase reflects true elevations in lactate, as propylene glycol is its principal metabolite. Urinalysis often reveals calcium oxalate crystals, spindle-shaped in monohydrate form and envelope-shaped in dihydrate form, in cases of ethylene glycol poisoning. However, these findings are neither highly sensitive nor specific for diagnosis. Some antifreeze brands contain fluorescein, which can cause urine fluorescence when examined under a Wood's lamp within the first 6 hours. Despite this, the test has limited utility because false positive and negative results are common. Regarding serum glucose levels, hyperglycemia greater than 140 milligrams per deciliter in individuals without diabetes has been linked to an increased risk of death following methanol poisoning. Initial blood tests should include evaluations of serum electrolytes, calcium, blood urea nitrogen, and creatinine, along with urinalysis. In ethylene glycol poisoning, low calcium levels may be observed along with a prolonged QT interval due to calcium oxalate crystal deposition. Patients suffering from methanol poisoning who experience abdominal pain should undergo assessments of liver function and serum lipase to check for hepatitis or pancreatitis. It is generally not recommended to conduct troponin testing unless ischemic symptoms are present. Electrocardiograms in cases of methanol poisoning can display various abnormalities, including increased heart rate, prolonged QT interval, right bundle branch block, and extended PR interval. However, these do not reliably correlate with clinical outcomes. A prolonged QT interval can also result from low calcium levels associated with ethylene glycol poisoning. Neuroimaging studies such as computed tomography or magnetic resonance imaging often reveal characteristic brain abnormalities in methanol poisoning, especially bilateral basal ganglia lesions and necrosis of the putamen. These lesions can occur without hypoxia. Although these imaging features are specific, their routine use is unclear unless neurological symptoms are evident upon physical examination. Diffusion-weighted magnetic resonance imaging can detect early cytotoxic edema. The effective management of toxic alcohol poisoning is a vital aspect of emergency toxicology. It involves providing immediate life support, preventing further toxin production, and enhancing the elimination of harmful compounds from the body. Recognizing the condition early and intervening promptly are essential to reduce the risk of severe illness and death. Management begins with immediate resuscitation and supportive care. This includes addressing the patient's airway, breathing, and circulation. Patients suffering from severe poisoning often require intubation and mechanical ventilation due to respiratory depression and coma. Hypotension, which can result from alcohol-induced blood vessel dilation and vomiting, is common and typically necessitates fluid resuscitation using intravenous crystalloids. Gastrointestinal decontamination is generally not recommended for toxic alcohol poisonings because these substances are absorbed quickly and do not bind well to activated charcoal. However, in cases where the patient is intubated, placing a nasogastric tube and aspirating gastric contents may be considered if absorption of the toxin is still ongoing. The primary approach to treating poisoning caused by methanol and ethylene glycol involves preventing these substances from being metabolized into their highly toxic acidic byproducts. This goal is achieved by inhibiting the enzyme alcohol dehydrogenase through competition. Two agents can be used for this purpose: fomepizole and ethanol. Fomepizole, also known as 4-methylpyrazole, is an important medication used in the treatment of toxic alcohol poisoning. It is particularly effective in cases involving methanol and ethylene glycol. The drug works by competitively inhibiting the enzyme alcohol dehydrogenase. This inhibition prevents the formation of highly toxic metabolites that can cause severe clinical complications. By blocking the enzyme's activity, fomepizole helps to reduce the risk of serious health outcomes associated with these poisonings. Historically, pyrazole was known for its ability to inhibit alcohol dehydrogenase, an enzyme crucial in the metabolism of certain toxins. It was effective in improving survival rates in animals poisoned with methanol and ethylene glycol. However, pyrazole was associated with significant side effects. These included the inhibition of other liver enzymes and toxicity to the bone marrow, liver, and kidneys, especially when alcohols such as ethanol and methanol were present. This adverse profile prompted researchers to search for safer alternatives. The efforts led to the discovery of 4-methylpyrazole, also known as fomepizole, in 1969 by scientists Lee and Tayarel. Fomepizole was found to effectively inhibit alcohol dehydrogenase in human liver preparations. Moreover, it exhibited relative safety in both animal and human studies, regardless of whether ethanol was present. This development marked an important step towards safer treatment options for poisoning by methanol and ethylene glycol. Fomepizole has a molecular weight of 82 daltons and functions as a potent competitive inhibitor of alcohol dehydrogenase, an enzyme to which it binds with very high affinity. By attaching to this enzyme, fomepizole effectively prevents the metabolism of methanol into formaldehyde and then into formic acid. Similarly, it hinders the oxidation of ethylene glycol into various toxic metabolites, including glycoaldehyde, glycolic acid, glyoxylic acid, and oxalic acid. This inhibition is vital because the parent alcohols, methanol and ethylene glycol, are considerably less toxic than their metabolic byproducts. To achieve effective inhibition of methanol metabolism, serum concentrations of fomepizole are maintained at levels sufficient to inhibit alcohol dehydrogenase. Studies have demonstrated that a concentration of approximately 0.9 to 1 micromoles per liter in the human liver is necessary to inhibit this enzyme. Current dosing strategies aim to reach serum concentrations between 100 and 300 micromoles per liter to ensure a safety margin. The pharmacokinetics of fomepizole indicate that its volume of distribution is approximately 0.6 to 1 liters per kilogram. The drug is metabolized into 4-carboxypyrazole, an inactive metabolite, which accounts for about 80 to 85% of the administered dose. Fomepizole exhibits nonlinear and saturable kinetics, with autoinduction of its own metabolism occurring after 36 to 48 hours of multiple dosing. After 96 hours, the elimination process shifts to first-order kinetics, characterized by a half-life of approximately 1.5 to 2 hours. Its renal clearance is low, with only about 3% of the dose excreted unchanged in the urine. When administered orally, fomepizole has been shown to produce serum concentrations similar to those achieved by intravenous administration, although an oral form is not currently available in the United States. The elimination of fomepizole can be reduced by approximately 50% in the presence of ethanol and by about 25% in the presence of methanol. Methanol poisoning occurs when methanol is ingested, leading to the accumulation of formate, a toxic metabolite responsible for severe metabolic acidosis, mitochondrial toxicity, and unique damage to the retina and basal ganglia. Fomepizole effectively prevents the buildup of formate, and human experience along with case series have demonstrated its inhibitory effect and overall efficacy in treating methanol poisoning. Notably, early treatment with fomepizole can reverse visual impairment if administered before permanent damage occurs. In cases of ethylene glycol poisoning, fomepizole prevents the sequential oxidation of ethylene glycol into highly toxic metabolites such as glycolic acid and oxalic acid. Glycolic acid causes metabolic acidosis, while oxalic acid leads to calcium oxalate crystal deposition and acute kidney injury. The use of fomepizole has been shown to effectively prevent the buildup of glycolate. In uncomplicated cases of ethylene glycol poisoning, administering fomepizole before the onset of renal failure can reduce or eliminate the need for hemodialysis. After this treatment, the half-life of ethylene glycol is approximately 14 to 17 hours in patients with normal kidney function and about 49 hours in those with impaired kidney function. Diethylene glycol poisoning occurs when the metabolism of diethylene glycol is blocked by fomepizole, preventing the formation of nephrotoxic and neurotoxic metabolites, primarily 2-hydroxyethoxyacetic acid and diglycolic acid. Animal studies and case reports suggest fomepizole's effectiveness in limiting the toxicity of diethylene glycol. Early administration of fomepizole in suspected or confirmed cases is recommended to prevent kidney damage, alongside urgent hemodialysis in severe cases. Fomepizole is not indicated for the treatment of isopropanol poisoning. Isopropanol is metabolized into acetone, which does not produce a toxic carboxylic acid. Inhibiting alcohol dehydrogenase would simply prolong the metabolism of isopropanol into acetone without providing any clinical benefit. Fomepizole has become the preferred method of inhibiting alcohol dehydrogenase in the United States, despite being more expensive than ethanol, because of its significant advantages. It is highly effective and reliable, as it consistently inhibits alcohol dehydrogenase without the need for regular monitoring of drug levels. In contrast, ethanol requires frequent monitoring due to its rapid and unpredictable metabolism. In terms of safety, fomepizole does not cause central nervous system depression or inebriation, which are common and problematic side effects of ethanol. This is particularly important when methanol or ethylene glycol also contribute to central nervous system depression. Fomepizole is associated with fewer adverse effects and medication errors. Conversely, ethanol infusion can lead to hypotension, respiratory depression, low blood sugar levels, hyponatremia, pancreatitis, and gastritis. Although fomepizole has a higher initial cost, the overall expenses for hospital care, including intensive care unit monitoring and laboratory tests, might be comparable to or less than those for ethanol. This is especially true if fomepizole prevents the need for dialysis or prolonged stays in intensive care. However, some studies indicate that ethanol combined with dialysis can be less costly in certain healthcare systems. In situations involving mass poisoning outbreaks or resource-limited settings where fomepizole may be scarce or transportation delays are significant, oral ethanol remains a viable alternative for initial or pre-hospital treatment. The recommended dosing regimen for fomepizole involves an initial loading dose of 15 milligrams per kilogram, administered intravenously. This is followed by a maintenance dose of 10 milligrams per kilogram every 12 hours for 4 doses. After 48 hours of therapy, the dose should be increased to 15 milligrams per kilogram every 12 hours due to the autoinduction of the drug's metabolism. During hemodialysis, the dosing frequency must be increased to every 4 hours to compensate for the removal of the drug by dialysis. Fomepizole should be diluted in 100 milliliters of 0.9% sodium chloride solution or 5% dextrose in water. It should then be infused over 30 minutes to minimize venous irritation. The therapy should be continued until the serum toxic alcohol concentration drops below 25 milligrams per deciliter or below 10 millimoles per liter for methanol. Additionally, treatment should persist until any acid-base disturbances have resolved. Fomepizole is generally well tolerated by patients and is associated with a low frequency of adverse effects. Common side effects include headache, which occurs in about 14% of cases, nausea in approximately 11%, and dizziness. Some patients also experience increased drowsiness and a metallic taste or dysgeusia in about 6% of cases. Less frequently reported effects include inflammation at the site of infusion, rash, fever, and eosinophilia. A transient increase in aminotransferase levels is the most common laboratory abnormality observed. While reports have documented cases of bradycardia and low blood pressure, particularly during hemodialysis in patients with severe acidemia, establishing a direct causal relationship with fomepizole remains unclear. Importantly, studies have confirmed that fomepizole does not cause retinal toxicity. It is noteworthy that one patient received fomepizole 99 times for recurring self-ingestion of ethylene glycol without experiencing any adverse effects. Children. Fomepizole has been successfully used in pediatric patients who have ingested ethylene glycol or methanol. The dosing in children is generally similar to that in adults, based on body weight. Pregnancy and lactation. Fomepizole is classified as pregnancy category 3. The risks associated with untreated poisoning from methanol and ethylene glycol, including the possibility of neonatal death, are very severe. Therefore, fomepizole is recommended for pregnant women either when toxicity is present or anticipated. If fomepizole is not available, ethanol can be used after a careful assessment of the risks and benefits. Because of its low molecular weight, fomepizole is likely to pass into breast milk along with toxic alcohols. Consequently, it is advisable to temporarily stop breastfeeding until both the toxic alcohols and fomepizole are fully eliminated from the body. In the larger context of alcohol dehydrogenase inhibition for toxic alcohol poisonings, ethanol plays a historical and, in some settings, ongoing role as a competitive substrate. Its therapeutic use is predicated on its ability to block the metabolism of more dangerous alcohols like methanol and ethylene glycol to their toxic byproducts. Ethanol primarily acts as a competitive substrate for alcohol dehydrogenase, an enzyme involved in metabolizing various substances. By competing with other compounds, ethanol inhibits the breakdown of xenobiotics such as methanol and ethylene glycol, which rely on this enzyme for metabolism. Alcohol dehydrogenase has a much higher affinity for ethanol than for other toxic alcohols. In laboratory experiments using human liver cells, the molar affinity for ethanol was found to be 77 times greater than for ethylene glycol and 15.5 times greater than for methanol. This large difference in binding affinity means that when sufficient concentrations of ethanol are present, the enzyme will favorably metabolize ethanol over the toxic alcohols. This preferential metabolism prevents the formation of harmful metabolites from methanol and ethylene glycol. Ethanol has been used as an antidote for methanol poisoning since the 1940s and for ethylene glycol poisoning since the 1960s. Although fomepizole is generally the preferred antidote in the United States, ethanol remains a viable option in many parts of the world where fomepizole may not be available. Ethanol is indicated when there is a known or suspected ingestion of methanol or ethylene glycol. This is especially true in cases presenting with metabolic acidosis, clinical features such as difficulty breathing or visual disturbances, or a history of potentially toxic ingestion. The goal of ethanol therapy is to quickly reach and maintain a therapeutic blood ethanol level of approximately 100 milligrams per deciliter, which is equivalent to 22 millimoles per liter. Some sources recommend a target range of 100 to 150 milligrams per deciliter. Treatment involves an initial loading dose of ethanol followed by a continuous maintenance infusion. The required amount of ethanol depends on the level of toxic alcohol present. Specifically, the molar concentration of ethanol should be at least a quarter of the molar concentration of the toxic alcohol, such as methanol. Oral administration of ethanol can be effective and may be particularly suitable in rural areas where close monitoring is not feasible and there may be delays in reaching a hospital. Intravenous ethanol is usually administered as a 10% solution through a central venous catheter or a peripheral vein, and the dosage is adjusted to maintain the target serum concentration. Dosing guidelines are available to assist clinicians, and during hemodialysis, maintenance doses generally need to be at least doubled to compensate for increased clearance. Ethanol is quickly absorbed into the bloodstream after oral intake, reaching its peak concentrations approximately 1 to 1.5 hours later. The rate of absorption can vary significantly due to various factors, including the dosage taken, the individual's fasting or nutritional status, gastric emptying speed, gender, genetic makeup, history of chronic alcohol consumption, and age. Once absorbed, ethanol is eliminated from the body through multiple pathways, including the kidneys, lungs, and extracorporeal methods, particularly when the metabolic process that breaks down toxic substances is inhibited. Additionally, the administration of ethanol can extend the half-life of toxic alcohols such as methanol and ethylene glycol. For example, in patients undergoing ethanol therapy, the half-life of methanol has been reported to be around 46.5 hours, while that of ethylene glycol ranges from 14 to 17 hours in individuals with normal kidney function. Adverse effects and safety issues. Ethanol therapy can lead to several complications, requiring admission to an intensive care unit and close monitoring. These adverse effects include central nervous system depression, which can be exacerbated by ethanol, especially at supertherapeutic concentrations. Such high levels may result in respiratory depression. Metabolic disturbances are also possible, with hypoglycemia and hyponatremia being common concerns. Additionally, gastrointestinal issues such as pancreatitis and gastritis have been reported. Administrating ethanol presents challenges due to the rapid and often unpredictable rate of its metabolism, which can cause fluctuating serum concentrations. Therefore, frequent monitoring of serum ethanol levels, blood glucose, and electrolytes is essential. An increase in the anion gap or a decrease in bicarbonate levels may indicate inadequate blockade of antidiuretic hormone activity, necessitating an adjustment in ethanol dosing. Furthermore, ethanol can influence drug interactions by inducing and inhibiting the enzyme cytochrome P450. This effect can lead to unwanted drug interactions and pharmacokinetic tolerance if ethanol therapy is continued over several days. Ethanol is classified by the United States Food and Drug Administration as a pregnancy Category C drug, which means that its safety during pregnancy has not been fully established and it should be used with caution. Ethanol is known to be teratogenic, potentially causing developmental harm to the fetus. Nevertheless, in cases of methanol or ethylene glycol poisoning, ethanol may be recommended for pregnant women if fomepizole is not available. Such decisions should be made after a careful assessment of the risks and benefits, especially during the second or third trimester of pregnancy. Ethanol can pass into breast milk, which raises concerns about its effects on a nursing infant. During ethanol therapy, breastfeeding should be temporarily discontinued until the ethanol and any toxic alcohols are eliminated from the mother's system. This precaution helps prevent central nervous system depression and toxicity in the infant. The primary toxic metabolite of methanol is formic acid, formate, while ethylene glycol is metabolized to glycolic acid and oxalic acid. The toxicity of these metabolites is significantly influenced by their protonation state. Formate, for instance, is considerably less toxic than undissociated formic acid. Undissociated formic acid exhibits a higher affinity for cytochrome oxidase in the mitochondria, which is the ultimate target site for its toxicity and is better able to diffuse into target tissues. Alkalinization through a bicarbonate infusion causes a shift in equilibrium that favors the less toxic, dissociated form of various organic acids. This shift occurs according to the principles described by the Henderson-Hasselbalch equation. By keeping these harmful metabolites in an ionized state, bicarbonate provides two significant benefits. First, ionized molecules are less capable of penetrating critical tissues such as the brain and retina, which reduces the risk of direct cellular damage. Second, molecules in their ionized form are less likely to be reabsorbed in the renal tubules, leading to their trapping in the kidneys. This process facilitates the excretion of these metabolites through the urine, thereby aiding in detoxification. Aggressive treatment of metabolic acidosis using sodium bicarbonate infusion is a widely accepted approach in cases of poisoning by toxic alcohols. It is considered reasonable to administer bicarbonate to patients who exhibit suspected methanol poisoning accompanied by significant acidemia. Similarly, in cases of ethylene glycol poisoning and life-threatening metabolic acidosis, bicarbonate treatment is also recommended. In instances of diethylene glycol poisoning, especially when the metabolic acidosis is moderate or severe, indicated by a base deficit greater than 10 millimoles per liter, bicarbonate therapy may be appropriate. Additionally, patients suffering from severe metabolic acidosis caused by low molecular weight polyethylene glycols or other specific poisonings, with a base deficit exceeding 10 millimoles per liter, should also be considered for bicarbonate treatment. The therapeutic goal for bicarbonate administration is to normalize the pH, with a reasonable endpoint being a blood pH greater than 7.20. Some sources advocate for the full correction of acidosis. Administering bicarbonate requires careful consideration of the dosage and method of delivery. Significant amounts of bicarbonate may be necessary to correct the blood pH effectively. In the initial stages of treatment, doses ranging from 500 to 800 millimoles, or even more, may be required within the first few hours. For rapid improvement of blood pH, hypertonic bicarbonate can be used initially. This form of bicarbonate is often administered as slow intravenous injections of ampoules. Once the desired pH level is approached, isotonic bicarbonate may be introduced as a continuous infusion. This helps to maintain the elevated pH without causing an increase in sodium levels in the blood. The amount of bicarbonate needed can be estimated by calculating the bicarbonate deficit in the patient. However, it is important to note that ongoing alcohol metabolism will continue to produce additional acid, which may necessitate adjustments to the bicarbonate administration plan. From a pharmacist's perspective, several important points about bicarbonate therapy need to be emphasized. Firstly, bicarbonate infusion serves as a vital temporary measure to manage severe acidosis and functions as a bridge to hemodialysis. However, it is not intended to replace hemodialysis, which remains the definitive treatment for removing both the parent alcohol and its toxic metabolites from the body. Additionally, when treating methanol poisoning accompanied by acidosis, it is essential to use alkali therapy alongside alcohol dehydrogenase inhibitors such as fomepizole or ethanol. Without inhibiting the enzyme responsible for metabolizing methanol, there is a risk that the acidosis could become resistant to bicarbonate treatment, as more formic acid continues to be produced during methanol metabolism. The potential for adverse effects exists when correcting acidosis rapidly, especially if the patient also has low calcium levels. Such rapid correction may trigger signs of muscle tetany. Therefore, it is essential to closely monitor electrolyte levels, particularly calcium, during treatment. Regarding the evidence supporting treatment outcomes, studies have indicated that administering bicarbonate alone has led to better-than-expected results in some uncontrolled case series involving severe methanol poisoning. However, the additional benefit of using bicarbonate in combination with inhibitors of antidiuretic hormone and hemodialysis remains uncertain, as some studies have shown mixed results. Additionally, the severity of the metabolic acidosis has been identified as a strong predictor of severe neurological effects. Nonetheless, it has not been conclusively demonstrated that alkalinization by itself can prevent these neurological effects. Diethylene glycol-specific treatment considerations vary across different sources. One source recommends using bicarbonate for moderate to severe metabolic acidosis caused by diethylene glycol poisoning. Conversely, another source explicitly states that intravenous sodium bicarbonate therapy for controlling metabolic acidosis in cases of diethylene glycol poisoning has not been studied and is therefore not routinely recommended at this time. This is despite the fact that acidemia may potentially increase the toxicity of diethylene glycol's metabolites. This divergence in recommendations highlights the importance of careful clinical judgment when managing such cases. Medical professionals may also need to consult with a toxicologist who specializes in poisonings to determine the most appropriate course of action. Hemodialysis is considered the definitive therapy for patients experiencing symptoms due to poisoning by toxic alcohols. It is effective because it removes both the parent alcohols and their toxic metabolites from the bloodstream, while also correcting acid-base imbalances and addressing electrolyte abnormalities. The indications for hemodialysis include severe metabolic acidosis, especially if it does not respond to bicarbonate therapy and medications that inhibit antidiuretic hormone. Signs of end-organ toxicity such as coma, seizures, acute kidney injury, and visual impairment also warrant this treatment. Additionally, significantly elevated concentrations of toxic alcohols in the blood serve as criteria for dialysis. Specifically, in cases of methanol poisoning, severe symptoms such as coma, seizures, or new visual deficits are clear indications. Hemodialysis is recommended if the methanol blood concentration reaches or exceeds 15 millimoles per liter or approximately 48 milligrams per deciliter. A pH of 7.15 or less, which does not improve despite bicarbonate therapy, also indicates the need for dialysis. Moreover, ingestion of more than 1 gram per kilogram of methanol or a blood methanol concentration higher than 16 millimoles per liter, equivalent to 50 milligrams per deciliter, are additional criteria for treatment. Formate levels, the toxic metabolite of methanol, are considered better predictors of clinically significant toxicity than methanol levels alone when deciding on hemodialysis. In cases of ethylene glycol poisoning, indications include severe metabolic acidosis with signs of end-organ damage, a blood ethylene glycol concentration exceeding 6 millimoles per liter, or an elevated osmolar gap if specific levels are unavailable. The concentration of glycolate, the toxic metabolite, is a more reliable predictor of death and kidney injury than ethylene glycol levels alone. When considering hemodialysis, it is worth noting that this procedure might also reduce the duration of fomepizole therapy, potentially making treatment more cost-effective. For methanol poisoning, intermittent hemodialysis has been shown to be more effective than continuous methods for eliminating both methanol and formate, the primary toxins involved. Adjunctive therapies are essential in supporting patients and reducing the severe effects of toxins and their metabolites, complementing definitive treatments such as inhibition of alcohol dehydrogenase and hemodialysis. While these therapies are often not sufficient on their own to serve as definitive treatments, they play a crucial role in optimizing patient outcomes. In cases of methanol poisoning, the use of folic acid or folinic acid, also known as leucovorin, is recommended. These therapies are believed to enhance the body's ability to clear formate by promoting its metabolism into carbon dioxide and water. Some animal species, such as rats, show less susceptibility to the retinal toxicity caused by methanol because they have relatively high hepatic folate stores, which facilitate the clearance of formate. The standard dose of folinic acid administered intravenously is 50 milligrams 4 times daily. However, it is important to note that the clinical efficacy of this treatment in humans has not yet been definitively established. Thiamine and pyridoxine are vitamins that are sometimes used in specific cases of toxic alcohol poisoning based on theoretical benefits. For example, in cases of poisoning with ethylene glycol, these vitamins are thought to promote alternative metabolic pathways for glyoxylic acid, a metabolite of ethylene glycol. This process may lead to the formation of non-toxic metabolites such as ketoadipate and glycine. However, there is limited supporting data from human studies to confirm the effectiveness of this antidotal treatment, and its routine use is not universally recommended. Despite this, Because administering these vitamins is considered safe and inexpensive, it is reasonable to give standard doses of thiamine to patients with suspected or confirmed poisoning by ethylene glycol. In the case of diethylene glycol poisoning, although there is no specific documentation, thiamine should be administered to protect against neurological complications, especially if the patient has a history of alcohol abuse. Thiamine hydrochloride is also included as part of the initial treatment for any patient presenting with altered mental status to prevent or treat Wernicke encephalopathy. This condition is particularly common among malnourished individuals who abuse alcohol. In such cases, higher doses of thiamine, such as 500 milligrams administered intravenously 3 times daily for 2 to 3 days, are recommended for effective treatment of Wernicke encephalopathy. Corticosteroids have been explored for their potential benefit in the treatment of methanol-induced optic neuropathy. Although limited data support their routine use, some uncontrolled case series have shown improvements in vision following treatment with corticosteroids. It is considered reasonable to administer 1 gram of methylprednisolone daily for 3 days, as the low risk associated with this dosage may outweigh the potential for benefit, especially considering the severe clinical outcome of vision loss. Additionally, retrobulbar injections of triamcinolone have demonstrated some improvement in vision in patients suffering from optic neuritis. Stem cell transplantation is an emerging therapy for methanol poisoning. This treatment shows promise, especially in cases where vision loss occurs as a result of methanol poisoning. In a case series involving 5 patients who were completely blind due to methanol poisoning, significant recovery of vision was observed after receiving stem cell treatment. Aluminum citrate is a potential adjunctive therapy for treating ethylene glycol poisoning. It is hypothesized that this compound interacts with the surface of calcium oxalate monohydrate crystals, preventing their aggregation. This mechanism could potentially decrease tissue damage, as demonstrated in an in vitro model using human proximal tubule cells. However, there are currently no in vivo human studies or case reports supporting the use of aluminum citrate for this purpose. Therefore, it cannot be recommended for clinical use at this time. Magnesium sulfate is recommended when administering thiamine. Evidence indicates that magnesium supplementation can enhance the activity of transketolase, an enzyme that depends on thiamine. Therefore, adding magnesium during thiamine treatment may be beneficial. The suggested dose is 2 grams of magnesium sulfate to be given intravenously to patients with normal kidney function. Early recognition of an epidemic and effective communication to identify affected individuals are crucial. Strategies include text messaging, radio broadcasting, encouraging patients to find drinking partners, and loudspeaker announcements. Syndromic surveillance, and, where politically feasible, shutting down local bars can limit the outbreak's extent. Empiric pre-hospital oral ethanol administration is another strategy. Triage decisions for allocating antidotal therapy and hemodialysis resources may be necessary due to overwhelmed local capacity. Pregnant women should be aware that toxic alcohols can easily cross the placenta, which poses significant risks to the developing fetus. In cases where an antidote is necessary, fomepizole is generally the preferred option. If fomepizole is unavailable, ethanol may be used as a temporary measure after careful consideration of the potential risks and benefits, since untreated poisoning can have more severe consequences. During treatment, breastfeeding should be temporarily discontinued because both the toxic alcohol and the antidotes, fomepizole or ethanol, can pass into breast milk. Children can become seriously ill from toxic alcohol poisoning, similar to adults. However, smaller amounts of ingestion are often sufficient to reach dangerous serum concentrations in children, highlighting the importance of assessing each case carefully. The treatment approach for children generally parallels that of adults, with both ethanol and fomepizole serving as effective antidotes. Let's condense this information into the high-yield points you need to know. Think of this as your quick reference guide before rounds or an exam. Toxic alcohols refer to alcohols, other than ethanol, that are not intended for ingestion. The most clinically significant among these are methanol, ethylene glycol, and isopropanol. Other examples include diethylene glycol and propylene glycol. Alcohols are hydrocarbons with a hydroxyl group, and they are classified based on their chemical structure into primary, secondary, diols or glycols, and glycol ethers. Methanol, also known as methyl or wood alcohol, is a one-carbon primary alcohol that appears as a clear, colorless, volatile, and flammable liquid with a weak ethanol-like smell. It is most commonly ingested through windshield washer fluid, model fuels, solid cooking fuel, and illicitly distilled beverages. Inhalation and transdermal absorption are also possible. When ingested, methanol causes mild central nervous system depression directly, but its toxicity mainly arises from its metabolites. Methanol is metabolized by alcohol dehydrogenase to formaldehyde, which is then rapidly converted by aldehyde dehydrogenase to formic acid. Formic acid is the primary toxic metabolite that inhibits cytochrome oxidase, leading to severe metabolic acidosis with an increased anion gap. Clinically, poisoning with methanol has a latent period of 12 to 24 hours, which can be prolonged if alcohol such as ethanol is also ingested. Symptoms during the symptomatic phase include severe metabolic acidosis, visual impairment such as blurry vision, snowfield vision, or even permanent blindness, and neurological effects like bilateral basal ganglia lesions, putamen necrosis, and Parkinsonism, which can be permanent. Ethylene glycol, also known as 1,2-ethanediol, is a diol with two hydroxyl groups. It is a colorless liquid with an aromatic odor and a characteristic sweet taste. This substance is widely used as antifreeze, a degreasing agent, and in various household products. Its sweet taste increases the risk of accidental or intentional poisoning. Ethylene glycol toxicity results mainly from its metabolites. It is metabolized by alcohol dehydrogenase and aldehyde dehydrogenase into glycoaldehyde, then glycolic acid, glyoxylic acid, and finally oxalic acid. The clinical presentation occurs in 3 stages. The first stage, CNS depression, occurs within 30 minutes to 12 hours after ingestion and mimics ethanol intoxication, causing inebriation and gastric irritation. The second stage involves cardiopulmonary effects like myocardial dysfunction, shock, and acute respiratory distress syndrome, occurring from 12 to 24 hours. The final stage is renal failure, which develops between 24 and 72 hours, primarily due to calcium oxalate crystal deposition in the renal tubules, leading to acute kidney injury. Hypocalcemia may also occur due to oxalate precipitation. Isopropanol, or rubbing alcohol, is a clear, colorless, volatile secondary alcohol with a bitter taste and a fruity odor. It is most frequently found in hand sanitizers, de-icing agents, and as a component of rubbing alcohol at 70% concentration. It is reported as the most common toxic alcohol exposure to poison control centers in the United States. Isopropanol is metabolized in the liver by alcohol dehydrogenase directly into acetone. Unlike primary alcohols, it is not further oxidized by aldehyde dehydrogenase into carboxylic acids. The main clinical effects include central nervous system depression, which is twice as potent as ethanol, gastrointestinal irritation such as gastritis, and ketosis without metabolic acidosis. The acetone produced causes the ketosis and imparts a distinct sweet odor on the breath. Propylene glycol, a diol similar in structure to diethylene glycol, is used in environmentally friendly antifreeze, as well as in various intravenous medications and cosmetics as a solvent or diluent. It is metabolized by alcohol dehydrogenase and aldehyde dehydrogenase into lactate, acetate, and pyruvate. This results in high lactate levels and metabolic acidosis, which are generally well tolerated because these are direct metabolic products, not indicators of anaerobic metabolism. Clinically, poisoning presents with central nervous system depression and severe lactic acidosis, especially in cases of renal impairment or overdose. Benzyl alcohol was once used as a preservative in intravenous solutions. It is metabolized into benzoic and hippuric acids. It is notorious for causing neonatal gasping syndrome, a severe condition involving multi-organ dysfunction, metabolic acidosis, and sometimes death, particularly in neonates. Due to these risks, it has been discontinued in neonatal medicine. Diagnosing toxic alcohol poisoning can be challenging, especially without a clear medical history and when ethanol ingestion is involved. It is important not to delay treatment awaiting confirmed serum levels. Ideally, Measurement of parent alcohols and their metabolites such as formate, oxalate, and glycolate should be performed using gas chromatography. However, these tests are often sent out and cause delays. Emerging enzymatic assay methods may help address this issue. Various surrogate markers can assist in diagnosis, though each has limitations. Anion gap metabolic acidosis is a hallmark of methanol and ethylene glycol poisoning, but typically develops over 16 to 24 hours. Thus, the absence of this acidosis early on does not rule out poisoning. The osmolar gap serves as an early marker because parent alcohols are osmotically active. A significantly elevated gap, greater than 50 milliosmoles per liter, is highly suggestive but should be interpreted with caution, as it is neither highly sensitive nor specific and may normalize as metabolism progresses. Assessment of ethanol concentration remains vital. Ethanol acts as a preferred substrate for alcohol dehydrogenase and can be protective. Therefore, a low or zero ethanol level in an intoxicated patient should prompt further investigation. Elevated lactate levels can also be indicative, particularly in cases of methanol and ethylene glycol poisoning, due to increased ratios of NADH to NAD+ and the inhibition of oxidative phosphorylation. Certain metabolites, like glycolate from ethylene glycol, can cause false elevations in lactate readings on some blood gas analyzers, a phenomenon known as a lactate gap. Propylene glycol, used as a solvent in various medications, can also produce lactate. Additional clues for diagnosis include urinalysis revealing calcium oxalate crystals characteristic of ethylene glycol poisoning, urinary fluorescence in some antifreeze products, and neuroimaging showing basal ganglia lesions associated with methanol exposure. Management principles focus primarily on methanol and ethylene glycol, as isopropanol and propylene glycol usually do not require alcohol dehydrogenase blockade or dialysis for the parent compound. Immediate supportive care involves airway, breathing, and circulation management, along with fluid resuscitation for patients with low blood pressure. Gastric decontamination is rarely indicated due to rapid absorption of these substances. The cornerstone of therapy involves inhibiting the formation of toxic metabolites through alcohol dehydrogenase blockade. Fomepizole is generally preferred because it is a potent, competitive inhibitor that reliably blocks metabolism without the need for drug-level monitoring and has minimal central nervous system depression. Dosing adjustments may be necessary in cases of autoinduction and during dialysis, and the medication is usually well tolerated. Ethanol serves as an alternative treatment, especially in settings where fomepizole is unavailable. It is also a competitive substrate with a higher affinity for alcohol dehydrogenase than methanol or ethylene glycol. Treatment aims for a blood concentration between 150 and 200 milligrams per deciliter. However, using ethanol requires intensive monitoring and admission to an intensive care unit due to its unpredictable metabolism and adverse effects, including central nervous system depression, low blood sugar, and pancreatitis. Correcting metabolic acidosis involves aggressive infusion of sodium bicarbonate, which shifts equilibrium toward less toxic, ionized forms of metabolites, thereby reducing tissue penetration and promoting renal clearance. However, this should not replace hemodialysis, but should be combined with the use of alcohol dehydrogenase inhibitors. Hemodialysis is the definitive treatment for symptomatic patients, as it removes both parent alcohols and their toxic metabolites, corrects acid-base and electrolyte disturbances, and is indicated in cases of severe acidosis, end-organ toxicity such as coma, seizures, kidney injury, or visual impairment, or when toxic alcohol levels are critically high. Additional therapies include folate or folinic acid, which are recommended for methanol poisoning to accelerate formate clearance. Thiamine and pyridoxine may promote alternative metabolic pathways for glycolic acid and ethylene glycol poisoning and are reasonable to administer given their low risk, also benefiting patients with alcohol-related Wernicke encephalopathy. Magnesium sulfate, along with thiamine, has been suggested to improve enzyme activity involved in metabolism. Corticosteroids have been explored for methanol-induced optic neuropathy, although evidence remains limited. Nonetheless, they are low risk and may be considered. This overview covers the essential points for managing poisoning with toxic alcohols, emphasizing prompt diagnosis and intervention to prevent serious and sometimes irreversible damage. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.